So today we will go through discussing the historical and current concerns related to controlled substance prescribing and use. We hope that at the end of this, you'll have a better understanding of substance use disorders and considerations around evidence-based prescribing, recognizing patients at high risk for opioid and benzodiazepine overdose, and identify appropriate non-opioid, non-benzodiazepine, pharmacologic, and non-pharmacologic therapies for common conditions. So how did we get here? I think this is, been a really interesting trajectory across history, looking all the way back to the 1700s, when opium, morphine, and narcomania all became a thing. In the 1700s, colonial America we actually prescribed opium very regularly from doctors to manage pain, help with dysentery, cough, and other conditions. Laudanum was actually an opium compound that was easily available in a pill form. Moving forward to the 1800s to the 1830s was the founding of the isolation of morphine from opium. And then in 1855 is when the hypodermic needle came into existence. It arose in the time of the Civil War. Doctors used it to administer morphine to injured American soldiers. Moving through into the 1870s, narcomania became a thing. Physicians started to have concern that people were addicted to morphine and that opiate-containing pills bought over the counter maybe were something that could lead to addiction or abuse. Moving forward into 1898, that is when heroin came to be. A German pharma company actually synthesized heroin because it was thought to be a less addictive remedy for coughs and colds. Moving into 1900, heroin became free. Philanthropic organizations were passing out free heroin to help morphine addicts. So fast forward just 6 more years and we find ourselves in 1906 when the Food and Drug Administration came through with the Food and Drugs Act, where pharmaceutical companies became held accountable to labeling their products with dangerous ingredients. So alcohol, heroin, cocaine, these things have to have labels now. In 1914, the Harrison Narcotics Act came to be. And in the 1920s, hydrocodone was developed by a German pharmaceutical company. 1923, legal narcotics were banned under the U.S. Treasury Department Narcotics Division. And in 1924, we passed the Anti-Heroin Act, making the manufacturing and possession of heroin illegal in the United States. 1938, we fast forward, we had the Food and Drug and Cosmetic Act, ensuring tighter control and safety over medical devices. And then in 1955, so all of what's happened up until now, 1955, acetaminophen becomes available, and we recommend it for children only. Adults aren't really recommended to use acetaminophen for a few more years. In 1960, Hoffman LaRoche marketed the first benzodiazepine, chlorodiazepoxide. I should have had Amanda unmute for that. And saying that it was something that could be less toxic and less likely to cause dependence than older drugs. Diazepam followed in 1963. And by 1970, so just a 10-year period, benzodiazepines topped the charts at the most prescribed drugs. We really actually didn't even understand how they worked or their mechanism of action until 1975. In the 1970s and 80s, oxycodone and acetaminophen, hydrocodone and acetaminophen, Percocet and Vicodin respectively, both became available as short-acting painkillers. 1978, so 18 years after we discovered benzodiazepines, 2.3 billion doses of diazepam have been sold in the US. In the 1980s, just shortly after 2.3 billion people are taking diazepam, we deemed that opioids are safe. We put a letter out there that opioid addiction is actually very rare in anyone treated with narcotics. And then in 1986, there were a report in the Journal of Pain reporting that there were 38 published case studies showing that the chronic use of opioid analgesics is okay without any need for concern. In the late 1980s, concerns start to arise. Are there potentially not understood risks to abuse and dependence of both opioids and benzodiazepines? In 1990, the American Psychiatric Association launched a task force to investigate the dangers of benzodiazepines. And by 1996, 4.1% of the adult US population has been prescribed a benzodiazepine. In 1996, OxyContin hits the market and is advertised as a less addictive, short-acting cousin to combination opioids. 2002, opioid deaths are rising from opioid drugs, and it has surpassed 10,000 deaths now. In 2012, there are enough medications on the street that every single adult in the United States could have a bottle of pills. 2015, overdose deaths from prescription opioids and heroin reached 33,000, almost triple the amount of deaths in 1999. In 2016, the CDC decides that they need to release some guidelines for the safe prescribing of opioids, encouraging non-opioid therapies and lower doses and use of shorter acting medications. The New York Times estimated the drug overdose deaths to be the leading cause of death in Americans under 50. In 2016 and 17, former President Obama asked Congress for $1 billion to fight the opioid epidemic. And in 2017, President Trump signed the executive order to create the President's Commission on Combating Drugs and Addiction and the Opioid Crisis. In 2017, 85% of overdose deaths involved a benzodiazepine and an opioid. So this has been a love-hate relationship in the making for a very long time. Some of the articles and the advertisements you can see on here: Librium, escape to reality; diazepam, reduce psychiatric tensions; now she can cope thanks to Butasol; cocaine is for toothaches. Let's see, what are some of the other things on here? This is cube morphine, and of course, we all know that methylphenidate helps to relieve chronic fatigue and apathy. That's one of my favorite ones on there as a mental health provider. Barbiturates were actually introduced in the 1860s, and they were diverted from medical use due to their low therapeutic index and their high risk for suicide. We thought that these things had low risk of abuse and dependence and misuse, but we've learned a lot since these came into being. These are some of the recent news headlines. When we were putting this presentation together, we thought it would be interesting to look at the news. Of note, these were the news headlines in the 5 days prior to putting this presentation together in early September. So rainbow fentanyl in central Kentucky, what to know? Fentanyl's not a choice, it's murder. Drug overdoses remain a big challenge in Kentucky. International Overdose Awareness Day was recognized here at the Kentucky Capitol on August the 31st. We're holding vigils in Kentucky for families who've lost loved ones. And 2 men were arrested in Pulaski County for when law enforcement seized over 25 ounces of meth, nearly 10 grams of cocaine, and 102 pills. So these are, love-hate relationship with controlled substances and substances of misuse is continually evolving. So I want to go back in history just a little bit, and I promise this won't be totally a history lesson, but I think it's important for us to understand where we are now to know more about where we've come from. So in 1970, President Nixon signed the Controlled Substance Act into law. It replaced earlier laws and helped us to implement control in the prescribing and dispensing of psychoactive hallucinogens. That was also when we arrived at the 5-schedule classification system to identify drugs for abuse and the application of medicine versus risk for dependence. In 1973 was the birth of the Drug Enforcement Agency, followed by 1988, the Anti-Drug Abuse Act, and the founding of the Office of the National Drug Control Policy. In 2012, that is when Kentucky mandated the use of prescription drug monitoring programs, what we know today as Casper. And in 2016, the CDC published their first set of guidelines, as I mentioned, around safe prescribing of opioids. It's important to note that prescription drug monitoring programs are now widely used. So here's the 5-drug system. The classification undergoes continual revision. So medications can shift into a lower schedule if we find them to be, so they could shift down toward a Schedule 2 or 1 if we find them to be higher risk of abuse, dependence, or diversion. Similarly, they can shift toward a 5 or a 4 if we find them to be less risk. It's confusing to say higher or lower classes because the lower the class, the higher the risk. Anything scheduled as a Schedule 5 medication is thought to have the least risk for addiction and abuse, and has very wide medical use. Anything down at a Schedule 1 has really incredibly high abuse potential, no medical use potential, and there's really no opportunity, reason, or ability to prescribe or dispense or administer these medications. Just for your information and understanding, I did put some of the examples of these medications in the 5-schedule table that I have here. So an example of a Schedule 1 might be LSD or heroin. Schedule 2, you're looking at your opioid pain medications. Schedule 3, ketamine, anabolic steroids, testosterone. Schedule 4 is where you'll find your benzodiazepines and any of the Z drugs. And then Schedule 5 can often be prescribed and or found over the counter, or not found over the counter, but can be prescribed medications such as Gabapentin or Pregabalin. Schedule 6 are our over-the-counter medications, and no prescription is needed for those. So aspirin, caffeine, nitrous oxide, alcohol, and tobacco actually remain Schedule 6. So opioid deaths have continued to be on the rise in America. There have been over 564,000 deaths due to opioids between 1999 and 2020. It's a multi-layered problem that has had several distinct waves. So the first wave of overdose deaths began when increased prescribing of opioids arose in the 1990s. This involved both prescription opioids, and also then moving into 2010 was when we looked at kind of the rise and increasing deaths involving heroin. The third wave began in 2013. The increases in these deaths involved synthetic opioids, particularly those involving illicitly manufactured fentanyl. The market for illicitly manufactured fentanyl continues to change, and sometimes it's found in heroin, counterfeit pills, and cocaine. Many times opioid deaths also include over other medications and drugs. So this is a figure from the national database looking at what are the national drug-involved overdose deaths. As you can see, that has continued to climb steadily since 1999. There was one dip in the 2018, but other than that, we've kind of been on steady rise. The total number is there in blue. The females are illustrated in orange, and the male deaths are in yellow. Let's see. Overall, drug-related deaths rose, and then deaths involving synthetic opioids, benzodiazepines, and psychostimulants all continue to rise. Overall drug dose deaths rose from 2019 to 2020, with there being 91,799 drug overdose deaths reported in 2020. Benzodiazepine deaths, as I mentioned, have been on the rise as well. Those deaths increased 400% from 1996 to 2013. ED visits have gone up by 300% for opioid and substance-related problems between 2004 to 2011. And in 2017, benzodiazepines and other tranquilizers remained the third most commonly misused illicit or prescription drug, with them reaching over 2.2% of the population. Benzodiazepine prescriptions, interestingly, increased by 67% between 1996 and 2013. And as you can see here, this other graph breaks down deaths from synthetic opioids. That's this one where you can see it climbing way up here, the bright blue spike at the top. Psychostimulant abuse potential is very much on the rise. And worldwide rates of misuse continue to grow. Veterans enrolled in a study in 2018. It showed that healthcare utilization and suicide risk continued to increase for individuals using benzodiazepines, and higher mortality rates are found in individuals with COPD, presumably related to the risk for respiratory suppression. These graphs are outlining the national overdose deaths related to any opioid, as well as overdose deaths related to prescription-only opioids. As you can see, the any opioid deaths were at 68,630 in 2020, and the prescription opioid deaths were at 16,000. So on the rise and continuing to grow. Deaths involving psychostimulants and benzodiazepines. I put benzodiazepines here in the first graph. Those were at 12,200, almost 12,300 in 2020. Psychostimulants, opioid deaths involving a psychostimulant was actually at 23,837 in 2020. So a huge rise. You can look down, it looks like there were almost none in 2000, 2001, with it climbing all the way up past 20,000 in recent years. So after a steady increase in the overall national opioid dispensing rate starting in 2006, the total number of prescriptions dispensed peaked in 2012 with more than 255 million and dispensing rate of 81.3 prescriptions per 100 persons. The national opioid dispensing rate declined between 2012 and 2020. And in 2020, the dispensing rate had fallen to the lowest it had been in 15 years, which was at 43.3%. In 2020, they have climbed back up and remain very high in certain areas across the country. You can see Kentucky is the darkest of red here. How have the states done over time, 2006 to 2020, with Kentucky having greater than 107.1 prescriptions per 100 people. 75%, so nearly 92,000 drug overdoses in 2020 involved in opioid. This slide illuminates Kentucky-related only overdose deaths. There were 2,250 in 2021. And some more facts about Kentucky. So Kentucky is really affected by the diversion of prescription drugs, particularly hydrocodone and oxycodone, which are the most abused prescriptions in Kentucky. Provider education of prescribed opioids grew. And with that growth of education to prescribers and providers, individuals shifted to heroin and fentanyl. So the death rates of overdose have decreased related to prescription drugs, but it has increased in non-prescription opioid medications. In 2011, 378 million dosage units of opioid was prescribed in Kentucky. This is a state of 4.5 million people. In 2017, we were down to just 304 million dosages. Probably still some opportunity for improvement. 2020, Kentucky was the third highest state for age-adjusted overdose death rates and 17th in the total number of deaths. In 2021, as I mentioned, 2,250 Kentuckians died due to overdose, and it remains prescribed at an alarmingly high rate. There's been surges in methamphetamines, heroin, and street opioids. This little buddy up here in the corner, I have a funny sense of humor. So when I Googled Casper, Casper the soccer player came up. So he will be my mascot for all things Casper related now, and I hope you will adopt him as well. I think he's from a European national team. So Kentucky Controlled Substance Prescribing Act was put into state in 2012. Kentucky Good Samaritan law protects individuals seeking care while experiencing a drug overdose in some situations. The Kentucky administrative regulations outline what our requirements for prescribing of medications are. And Kentucky House Bill 1, which came into being in 2012, updated prescribing and dispensing standards for controlled substances, including mandatory continuing education, sanctions for prescribers not adherent to guidelines, requirements for pain clinics, and mandatory reports by professional licensure boards. So I suspect most of you are here not related to the House Bill 1 requirement, but for those of you who are, I'm glad that this will fulfill that requirement. The Kentucky All Scheduled Prescription Electronic Reporting, otherwise known as Casper, our little buddy up in the top. It is a mandatory registration for practitioners and pharmacists. It requires a query of Casper prior to prescribing or dispensing a Schedule 2 or 3 controlled substance containing hydrocodone, and every 3 months for continued use. Each licensure board has specific requirements, so know your own licensure board requirements. Providers authorized to prescribe and dispense controlled substances, we have to complete the CE, as I mentioned. So in addition to just running the report, we also have to obtain the patient's medical history, conduct a physical or mental health examination, depending on what the scope of the care is, query the patient database, make a written plan of the treatment, and discuss both the risks and the benefits with the patient. We're required to have written consent for the treatment on the patient in the patient's medical record, as well as reviewing the data ongoingly and with each new prescription with modifications to treatment as necessary. Let's see, there is an exemption to the paraphernalia laws, which the health departments operating in a harm reduction capacity can do syringe exchanges, and created a sharp object and needle declaration immunity designed to protect peace officers from accidental needle sticks while searching for suspects. Let me get some other highlights here. All right. So the prescription drug Jean is going to take over here for prescription drug monitoring. Did you get control, Jean?
Yes, I did. Good morning. Prescription drug monitoring programs, as we're known across the country, or PDMPs, were established. Actually, there's a long range of time there. I believe Hawaii was established back near the turn of the century, the 1900s, early 1900s, up to most of us are much more recent than that. We all have, we're all based in state statute and regulations. Our authority comes from state statute and regulations. However, there is authority in federal law too for certain aspects of our work. There are 53 prescription drug monitoring programs now around the country. There is one in all 50 states plus Guam, Puerto Rico, and the Northern Mariana Islands. And the actual growth of prescription drug monitoring programs and our growth in sharing data with other prescription drug monitoring programs has resulted definitely in a decrease in multi-provider episodes. Prior to PDMPs being as highly utilized as they are today, we had a lot of patients who would be seeing different providers across state lines, within a state, and with the use of PDMPs, we've seen that decrease. In Kentucky, we do share with 18 states, including our border states, and like that accounts for like 99.7% of the people from outside of Kentucky or coming to Kentucky come from the states with whom we share data. Just as far as what is in Casper, prescriptions are reported to us today if they were dispensed yesterday. So they have up until midnight today to report anything that was dispensed yesterday. That includes dispenses from pharmacies, emergency departments, physician offices, and so on. This just gives you a little bit of the history of Casper. We were actually established in 1997, but it took us a little while to get a full-blown, get statute in place, and then to get a full-blown system in place. And we were a paper-based system since 2005, or from up until 2005 when we launched an electronic system. We've been through many changes. Stay tuned if you're a Casper user, because at the end of this year, in 2022, we will be releasing a newly modernized Casper. We have been rewriting Casper from the ground up using newer technologies. And it's slated to go live just before Christmas this fall. We do collect, sorry, my mouse is acting a little flaky here. Okay, we do collect Schedule 2 through 5 controlled substances. You may not know, but states do have the authority to upschedule a controlled substance. So we can, in a state, move a controlled substance from a 5 to a 4, or a drug that is not scheduled to a Schedule 4 or 5. But we can't downschedule them. So we can't make anything less than the federal standard, but we can upschedule. There are several drugs that have been upscheduled within Kentucky. The most significant was when we upscheduled gabapentin. Gabapentin was present in over 40% of the overdose deaths a year prior to our scheduling it. And so we just scheduled it as a Schedule 5 so that we could see what was going on with gabapentin across Kentucky. And as you can see, gabapentin is the #1 prescribed controlled substance in Kentucky, accounting for 24% of the total controlled substance doses dispensed in the state in 2021. As we talked about earlier, it is mandatory to register for Casper if you are a practitioner with a DEA to prescribe controlled substances or a pharmacist licensed in the state of Kentucky. So if you have a DEA or a pharmacy license, and if you're a prescriber with a Kentucky license and a Kentucky DEA, you must have a Casper account. If you're a pharmacist with a Kentucky license, you must have a Casper account. If you want to make sure that your Casper account is active, I suggest that you log into your Casper account, and on the left-hand side, you'll see where you can print account verification for certificates. If you're unable to log in and print that certificate, you can follow the link here and go through the process of requesting a Casper account. Just a couple of things about the Casper account, and then I'm going to talk a little bit about the picture on the right-hand side. Your Casper account allows you to query. As Elizabeth said earlier, there are querying requirements for each licensor board, as well as Casper querying requirements. Be sure to be familiar with that. Run the reports as required. And just so you know, you can share that report with a patient. And you can include it in their medical records. A little side note, we are not actually permitted by statute to share the report with a patient. So if you have something you want the patient to know, please don't direct them to us. Share that report directly with the patient yourself, because if they call us and ask us to discuss what's on their Casper report, we're unable to do that. If you have a concern about what's on their Casper report, you can call us because we can discuss it with you. We just can't discuss it by statute. We cannot discuss it with the patient. It is also important to note that there are strict limitations on redisclosure. So beyond sharing it with the patient, I would urge you to be aware of who you can share that information with, because there are very strict limits on redisclosure. On the right-hand side here, you'll see our quarterly prescriber report card. I urge you to run this report and the one that I'm going to show you in just a few minutes, called a reverse Casper, on a quarterly basis at a minimum. This prescriber report card will show you your prescribing in comparison to other folks in your specialty, as well as all prescribers across the Commonwealth. It also highlights patients who are considered to be high-risk patients, whether they have multiple provider episodes or overlapping benzodiazepines and opioids. And at the end of the report, it tells you who those patients are. If you look at this report and think, well, this seems totally out of whack, be sure to look up and see what you have designated your specialty as. We found that some folks have inadvertently chosen the wrong specialty, and they might be a provider such as an orthopedic surgeon, and they're being compared to somebody who's in primary care, and their prescribing practice looked disproportionate to their specialty. So please check up there at the top and make sure that that is the correct specialty for you. We also urge you to run a reverse Casper on a quarterly basis. You can run it more frequently. And when you log into Casper to do that, it does default to 30 days. If you're doing it quarterly, you could just change it to a 90-day range. You can print or export this as a PDF, so you yourself don't have to necessarily review this report. You could have a team member, a staff member review the report, but this is going to show you everything that has been dispensed to your DEA in that period of time. And it shows you the patients and then every prescription per patient. You are the only ones who can tell us if something has been erroneously or fraudulently attributed to your DEA. So we urge you to run this report on a regular basis. Make sure the things on this report are correct. And if they are not correct, contact the dispenser to find out, why was this on my report? Was it a mistake that you made, or could it in fact have been a fraudulent prescription? If it's a mistake, it was an error on the part of dispenser, they have 7 days to correct that. And if they don't correct it within the 7 days, you can report that to us. If it's fraudulent, we ask you that you call both local law enforcement and us. We have quite a bit of diversion that still goes on in Kentucky. We've had surges recently in the diversion of promethazine with codeine. And so we need you folks out there in the field to be looking at these things and letting us know if something's been fraudulently attributed to your DEA. This is the Casper report, and everything I'm going to point out, the important pieces of information on the report, are also available through your integrated solution. They may be located a little differently, and I'll show you that in a minute, but the information is still there. To ensure that the report, if being run by your delegate, was actually run on your behalf, check this requester name up here. We have had folks who look like they were totally non-compliant with Casper querying requirements, and it turns out their delegate worked in another doctor's office part-time, and one is running all of their reports under that doctor instead of you. So you want to make sure that your name is up there on that upper right-hand corner. On the left side, the first box you'll see there shows you that we provide the demographic data for each variation of demographic data that we have for that patient, and that we assign that patient ID, which you can actually then look down the right-hand side of the report and see which prescriptions are attributed to that particular set of demographic data. We have limited data. And so if there's two people with the same name, with the same date of birth, or in the same geographic area, that kind of thing. And we don't have things like a social security number from both of them to actually separate them. They can become combined because we are looking for someone who has a high probability of being the same individual. So if you find something on here and you don't think that's your patient, you can actually then say to yourself, okay, well, I'm going to disregard everything from patient ID number 3, and even note it in your documentation or in your progress notes that you determined that that was not the patient and you disregarded that information. We'll give you the prescriber DEA city, and the prescriber pharmacy name or dispensing provider name appears. If it's a dispensing provider, it still appears under the pharmacy name. And we're adding additional information to the end of the record as well. Today you have the address there. We're working on a change right now where it would also show you that provider's phone number. Active prescriptions are always in bold. And then finally, here's your active cumulative morphine equivalent. Anything over greater than or equal to 90 has a 9 times higher risk of overdose death. So that's why we highlight that information as shown on the report. Right here on the right is your Bamboo Health. If you're using the integrated report, as I said, there's the same information is there. You can see the prescriptions. Under opioids, you'll see the current MME per day. That's the same as the ACME. Up at the top of the report, which you don't see here, you can see the patient's demographic data, much in the same way that you see it in the Casper report. This report, as you may know, is embedded within Epic, and it goes through a third-party vendor to get from your system to us at Casper. And you also have inspect data there from Indiana available as well. You do have to have a DEA and be registered with Casper to get this access. And we've been doing some significant compliance audits. So if you're not registered with Casper and are getting this within the system, please get your Casper registration completed as soon as possible. And finally, this will just tell you a little bit about who can query Casper, and it gives you the different user types and what they are allowed to use Casper data for. Also, you can find on our website, and if anybody's interested at the end of the call, they can indicate. I have a document that will show you all of the different licensure board requirements kind of rolled up into one as well. Going to turn it back over to Elizabeth.
I'll unmute. That was a good reminder for me. So just a reminder, the controlled substance requirement requires us to run this on initial prescribing and dispensing. We have to do this for the previous 12, it reviews the previous 12 months, and then again for 3 months ongoingly if the patient remains in treatment. Jean, I'm going to try to take control back over here. There we go.
You should have it. I gave it up.
Yeah, okay, perfect. Exceptions to the prescribing and dispensing regulations. So individuals in hospice and end-of-life care, cancer-related pain specifically, disasters, mass casualties, and a single dose for a procedure. You don't have to have that Casper report. Hospitalized inpatients and long-term care facilities, prescribing 2s or 3s containing hydrocodone. They must query Casper within 12 hours of admission or and looking at that patient's chart. Prescribing or administering 14 days or less after an operative or invasive procedure. And then if you're doing a substitute prescription within 7 days of the initial prescription. Same patient as your partner within 90 days, although that's only under specific coverage arrangements. And I would urge that good practice might mean going above and beyond any of these exceptions. And then additionally, research subjects enrolled in an IRB approved drug study with the specific NIH certificate of confidentiality. So the cabinet encourages all providers to adopt e-prescribing. That was of January 1st, 2022. There's very few exemptions to that. Mostly it arises in the context of an electronic failure. Written and fax prescriptions also have to be filed in the patient's chart. So there's just a lot of extra burdens when you aren't able to e-prescribe. Let's see, those who are hospitaled inpatient long-term care facilities, providers can query Casper within the 12 hours of admission for Casper on the chart, and then hospice. Some pharmacies, including retail pharmacies, will not accept written prescriptions, even in the context of technological or electrical failure. I feel like I'm going backwards. Okay. Here's some best practices. So review Casper anytime an illicit substance is suspected and for any patient at risk. Obtain a drug screen in the setting of illicit substances. Make sure you're looking at the prescription monitoring system for anything that could be suspicious. Patient history has to include documentation of any substance use history, including illicit or prescribed. So inclusive of treatment for first-degree relatives with a history of substance use concern or substance use treatment. And then you also need to have a documentation of what the patient's mental health concerns are. Making sure that there's thorough risk-benefit discussions and documentation, and then consent agreements around making sure that the patient education is on file, validating that the patient's going to take the medication as prescribed, they're not going to divert it to anyone else. And that they state agreement not to use illicit substances during the treatment period. Limiting polypharmacy as much as possible to limit the co-prescribing of benzodiazepines and opioids. So you want treatment to weigh out the risks and benefits. You want to make sure that the benefits improve symptom relief and provide quick benefit, and talking through every single risk that's possible. So dependence, abuse, addiction, withdrawal, problematic use, including diversion and misuse, harmful effects, and you want to maximize outcomes and minimize risks as much as possible. Generally, opioids are recommended for short-term use, and benzodiazepines are recommended for use for less than 2 to 4 weeks. Prolonging use of any of these medications can increase risks of tolerance and dependence, and extenuating circumstances might include terminal illness and acute grief-induced insomnia if there's no other risk factors present. You want to identify patients at risk. So anyone with a morphine equivalent over 90, co-prescribed benzos and opioids, history of alcohol substance use disorders, early refills, lost prescriptions, those are red flags, multiple prescriptions from multiple pharmacies and multiple doctors, and then anyone who's medically at risk. So anyone pregnant, breastfeeding, has COPD, geriatrics, sleep apnea, PTSD, and OCD. So misuse is when you take a medication at a higher dose than prescribed or without a prescription. Individuals' primary source benzodiazepines are from their families and friends. And I hear it in clinical practice all the time. Like, well, when I borrowed my so-and-so's alprazolam, it really helped me, which makes me want to like cover my ears and tell them, please do not tell me those things. And it also gives me a high index of suspicion that they're a sharer of their medications. And that is something that I need to do a lot of education around. So the estimated prevalence of misuse is 2%. There's increased prevalence up to 7.5% in individuals with psychiatric disorders. There's a 27% lifetime misuse in individuals who have a co-occurring alcohol use disorder, and a 70% chance of misuse in an individual with a co-occurring opioid use disorder. So very important to provide education and make sure that anyone at risk of diversion or being diverted from would be storing these medications safely, including in a locked safe. So the DSM-5 criteria for substance use disorders, it used to be broken into dependence and abuse. So under dependence, what we're going to look for as providers are things like loss of control, so more than intended use, can't cut down on using it, giving up activities to get it, craving it. And then are they having any evidence of tolerance or withdrawal when they do use the medication or run out of the medication? And then consequences, so formally abuse. So consequences that we look for, are they missing out on any work, school, or home obligations? Are there rising interpersonal problems? Are they putting themselves in dangerous situations? And are they some of those folks that are ending up in the ER or overutilizing their medical care and they didn't used to be? A person with a substance use disorder is defined by having 2 or more of those in the past year, and it results in distress and impairment. Tolerance and withdrawal alone are not enough to imply a disorder, and the severity rating, if they have 2 of the above mentioned, loss of control, physiology, or consequence, it's mild. 4 to 5 of those would be moderate, and then 6+ would be severe. So it is time for your first pop quiz. As long as I follow the minimum requirements for controlled substance monitoring, I will catch any patient at risk for development of an opioid benzodiazepine overuse concern. I'll let you enter your answers here, true or false. Oh, blarg. I left the answer on the slide. If you're adept at seeing the answer where I left it, you'll get it right. Thank goodness, everyone who read the slide got 100%. Great work. I'm going to turn it over to Amanda now.
All righty, thanks Elizabeth and Jean. So I think I have control now. So this really leads us to present day where we have some guidelines around opioid and controlled substance prescribing. And our most current guidelines were published in 2016, but these are actually currently undergoing some review. It was open for public comment until August 11th of this year. So likely sometime later this year, we will see some new and updated guidelines from the CDC surrounding prescribing opioids for chronic pain. So stay tuned for that. But these guidelines are really geared for primary care providers and practitioners who are prescribing opioids for chronic pain that is not active cancer treatment, palliative, or end-of-life care. So as we move through these opioid guidelines and the CDC guidelines, that is really the scope of these guidelines. And yes, this will let me move forward here. All right, so the CDC guidelines have 3 main focus areas, and they're right-minded when you think about it. So it's when to initiate or continue opioids for chronic pain, the opioid selection, the dosage, the duration, the follow-up, and the discontinuation of opioids, as well as assessing the risk and addressing the harms of opioids. So you see these 3 colors here. You'll also notice the 3 same colors in the top right of your screen. So as we move throughout these pillars, you'll see which pillar we're currently focusing on. So the first area that we will focus on is when to initiate or continue opioids for chronic pain. And so like many disease states, we know that non-pharmacologic therapy is one of the first things that we turn to for chronic pain. We also want to utilize non-opioid pharmacologic therapy when pharmacologic therapy is warranted. So this means that we are going to consider opioids when our benefits outweigh the risks for both pain and function. So it's having those discussions with patients, and we'll dive into that a little bit further. But even when we deem that opioids are warranted for therapy, we still want to ensure that non-pharmacologic and non-opioid therapies are being utilized. So some examples of some non-pharmacologic therapy include physical therapy. This can be specific physical therapy. This can be exercise therapy. This can go as far as weight loss and other counseling modalities, including psychological therapies, including cognitive behavioral therapies. It can also be interventional procedures. These can be like glucocorticoid injections. But when we use our non-opioid pharmacologic therapies, we think of acetaminophen, NSAIDs, specific antidepressants and anticonvulsants, and some have specific FDA indications for some of our most commonly seen pain conditions. And we will dive into a little bit deeper in terms of nuances of these non-opioid therapies, as well as specific pain conditions and what therapies are first line. So before initiating or starting opioid therapy, clinicians should establish treatment goals with all patients. So this is a discussion with the patient, stating that before we are going to prescribe opioids, what are our goals? What are our goals and what's our exit strategy? So really having a plan in place to be able to openly discuss what our plan is with these patients in terms of how long we're going to use them, the expectations around them, and what that looks like going forward versus just an opening statement of, okay, let's do an opioid, and we'll just keep going up until we keep going up. So it's really that discussion before we initiate therapy. Before initiating therapy, as well as periodically during opioid therapy, we will discuss the known risks and benefits of opioid therapy with our patients. So we know that opioids are going to help with the pain, but they are not going to help with the actual cause of the disease state. So we are going to advise patients on both the serious and common concerns of opioids. This includes the dependence, as well as those common adverse effects that we know all too well. So that constipation, the nausea, vomiting, dizziness, and again, that risk of dependence that comes along with it. We will also review our more serious side effects, so like the respiratory depression, especially when they are taken concurrently with benzodiazepines, other sedatives, alcohol, and illicit drugs. We will, before we start opioid therapy, we will have those discussions, but when we have had that discussion, we know we are going to continue with opioid therapy. We will turn towards our immediate release opioids before going to our extended release. So below here, you can see some examples of the extended release opioids. These include methadone, transdermal fentanyl, extended release oxycodone, hydrocodone, and morphine. Elizabeth, you had mentioned earlier that our most frequent flyers for opioids are oxycodone and hydrocodone. Typically, we see these co-formulated with acetaminophen. Those are examples of immediate release. However, when we are maybe further down the treatment algorithm and extended release opioids are in the discussion, it should be reserved for severe and continuous pain, and really only considered for those patients who have received immediate release opioids for at least daily for at least a week. And that's what the guidelines say. I think we can all agree that likely if we are going to discuss extended release opioids, like I mentioned earlier, it's kind of further down the treatment algorithm and potentially outside of the scope of primary care. This could be when pain management really comes up in the discussion and the referral could be entered. So when we think about selecting an opioid, as well as the dosage and duration, we know that a lot of long-term opioid use often begins with the treatment of acute pain. So this is your patient who had an injury, had an acute event, and is complaining of pain, whether this is lower back pain, shoulder pain, knee pain, hip pain, you name it, where something happened and it is warranted that they do get some sort of opioid therapy, and that it just turns into a few more days, a few more weeks, a few more months, and all of a sudden they're a chronic opioid user. So oftentimes when a patient presents with an injury or an acute pain indication, 3 days or less will often be sufficient, and rarely will 7 days be needed. This is a good opportunity for when patients do come to you with an acute need to just really use that immediate release opioid and prescribe no more than 3 days. That is ensuring not only will they follow up with you, but it lessens the likelihood of it extending into a chronic use. Okay, so when opioids are started, we should prescribe the lowest effective dose. Again, this is not uncommon to most disease states, so we want to use the lowest dose. So we're using an immediate release opioid for a short duration, and we want to use the lowest prescribed dose. So when we think of that, we want to when we think of going above 50 milligrams morphine mill equivalents per day, that is when we start to kind of go into the realm of a riskier regimen, and then increasing to more than 90 milligrams of morphine equivalents per day really should be a careful decision. And actually in some states, such as Washington, in order to go above that 90 MME threshold, prescribers have to get a consultation from a pain management physician. Kentucky does not have that requirement, but just goes to show that really that 90 MME threshold, as Jean alluded to really increases the risk of opioid use disorder as well as opioid overdose. So when we are evaluating the risks and harms with patients, this should of course be done at the initiation of therapy. So within 1 to 4 weeks, we would like to follow up to assess these risks and benefits. But we also want to do this every so often. So likely we'll see these patients, depending on their other comorbid conditions, at a 3 or 6 month interval. But we also want to make sure that we're doing this not just at initiation, but at the follow-up as well, because things change. New medications get started, new comorbid conditions arise. So we want to ensure that we are assessing their whole really problem list as well as medication regimen to ensure that we are addressing additional risks associated with our opioid use or that would put them at an increased risk of an overdose. So going through their whole medication profile each time and assessing these risks. Within the second pillar of the CDC guidelines, they do discuss the considerations for tapering opioids. And it's suggested that a decrease of 10% of the original dose per week is a reasonable starting point. This will be for most patients, but for patients who have a severe adverse event, such as an overdose, or if something else has been identified where they are maybe starting a new medicine, or we are going to want to rapidly decrease, about 2 to 3 weeks is that interval we can think of, but most patients it will take a little bit longer than that. Depending on other other things in the patient's life that is going on, or other disease states or other conditions, it's possible that that 10%, while it applies to most patients, could be a little bit different for your patient. You may have to go a little bit slower. You may have to pause. You may have to, just get creative with this taper, but usually that 10% is a good starting point. So let's look at an example here. So for example, if you have oxycodone acetaminophen 10-325 with the directions to take 1 to 2 tablets every 6 hours as needed for pain, very common prescription that we see. We can think of this as a daily oxycodone amount of about 80 milligrams. So, of 80 milligrams. So about 10% of the dose would be about 1 tablet daily of a decrease. So this means you could write the prescription, you could decrease the dose by 1 tablet per day, per week, until it's discontinued or that target dose is reached. So as a prescriber, this means that you may have to write shorter increments, whether that be 1 week or 2 weeks at a time, or if you are on the same page with your patient in terms of that whole month, that could be an option too. But I would recommend, we are working on a patient, right now in primary care, where it is clearly spelled out in their chart, the patient and prescriber are on the same page. We're going stepwise, and it's the expectation of each week what that will look like and what, how many number of tablets and directions per day, per week. When we think about tapering other controlled substances with benzodiazepines, we do have to be careful not to induce those withdrawal symptoms. The symptoms can range from mild to having some anxiety or insomnia, all the way up to seizure and psychosis in terms of a severe withdrawal. I'm sure Elizabeth has a breadth of experience with this, but really, it can take a long time. We think of 6+ months for some of these patients who have chronically been on benzodiazepines, and it takes a delicate hand to really work with the patient and reduce the dose by really up to 25%. That may be too steep for some patients. You may have to really go slower for some patients, and that's okay. But we do want to carefully taper down when we're thinking of benzodiazepines. When you think of patients who are on both benzodiazepines and opioids, it may be in the patient's best interest to taper one first and then the other. It may be a case where we have to go slower on both if we're going to do them at the same time. So that is considering your patient, considering where they are, considering the other circumstances. So, why are we discontinuing or tapering down? But really going slow and having that plan in place can help. In terms of gabapentin, it doesn't need a crazy extravagant taper schedule. It's just gradually reducing down over the course of about a week, sometimes two, depending on what's going on with the patient. But we can see some withdrawal symptoms such as confusion, irritability, and an increased seizure frequency in patients with epilepsy. For other stimulants, there is no taper required, and these can be abruptly discontinued. So here's an example of a simple and slow taper with diazepam. Diazepam 40 milligrams per day. So you can see here on the left-hand side, it is spelled out by week, and you'll notice that it says 18 milligrams in the morning and at night, and diazepam comes in not 18 milligrams, so you may have to get a little bit creative with some of the dosage forms. And this is just an example, but it goes to show how, we're doing 18, 16 twice a day on week 2, 14 twice a day on week 3. And on the right-hand side here, you can see the percent decrease. So it's not the exact same every week. It's really, like in this example, showing that it's a gradual process over time. And even on week 11 and 12, we're still down to 6 milligrams in the morning and 6 milligrams at night. And so we really go even farther past that. But using the available strengths of 2.5, 5, and 10 milligram tablets, you may have to, if they've been on the 10 milligram tablets for an extended period of time, it may be something where you have to use 1.5 of the 5 milligrams. And like I said, kind of get creative with the available and commercially available strengths. But having this written out like this for yourself when you are writing those prescriptions, but also for the patient to know the expectation and to know what's coming can be very helpful. So moving on to the third area of the CDC guidelines, assessing risk and addressing harms of opioid use. So before starting and then the periodic discussions when you are going to continue opioid therapy, clinicians should evaluate the risk factors for opioid-related harms and offer naloxone to mitigate those risks. So our high-risk patients, Elizabeth alluded to earlier, but it's those patients who have concurrent benzodiazepine use. When we see above 50 MMEs per day, and then patients who are over 65 who have mental health conditions, as well as non-fatal overdose in the past. These all increase our risks for opioid use and overdose. And this is really where the PDMP data comes into play. So Jean did a great job of highlighting how you can read and interpret the Casper data as well as the Bamboo data in EPIC. So seeing that before you prescribe an opioid therapy, in addition to at least every 3 months. And this is where knowing that patient, knowing if there are any red flags, would lead you to process this data more frequently, but at least every 3 months. Another way to assess the risks and address those harms is to perform a urine drug screen, a urine drug test. So when we think of a urine drug test, we have the screen versus the confirmatory, and the confirmatory really is just, it's more specific when you think of tests. And these tests in the middle here with the little bracket, it says these and other synthetic opioids require specific tests, and they're not detected by just testing for opiates. When you order a urine drug test in EPIC, it is specifically testing for these. You'll be able to see that breakdown when you order this test. But some red flags in terms of when you get a urine drug test back is showing how some of these can be altered. So when a patient can add a substance to their urine so that something appears off with it. It can be diluted with water. or the patient can provide a sample that's not theirs or from an earlier time. So what this would look like to you would be something coming back as an abnormal result. So the temperature, the specific gravity being off if it's less than 20 milligrams per deciliter, indicating it's been diluted. If the creatinine levels are outside of the normal, then it can be diluted or something has been added. And if the pH is off too, then another substance can be added. So if something seems off, it probably is. You know, if it, what's that saying? If it, you know, walks like a duck, talks like a duck, probably is a duck. It's, you know, kind of one of these things. If something seems off, it probably is. So getting that sample and also knowing that that has happened can lead you to have that patient as kind of a high-risk patient. This aligns with the CDC guidelines that urine drug tests should be used before starting an opioid therapy, and then at least annually to assess for prescribed medications as well as other controlled substances. So urine drug tests not only tell you if there is another substance, either prescribed or illicit, involved, but it also is testing for the drug that you're prescribing. So we should see the therapies that we are writing prescriptions for and that come up on our Casper results. If the drug that you're prescribing is not on their Casper report, then I think it's worth the discussion in terms of, hey, you know, you are taking oxycodone, acetaminophen, and that didn't flag on your urine drug test. Are you still taking this? And for some patients, if they say, no, you know, sometimes I just take it as needed and I didn't need it the day that I came in. Well, then that's a discussion in terms of de-escalating therapy and having the prescription that you're writing reflecting how they are taking it. So if it's being written for 3 to 4 times a day, sounds like that's, you know, allowing for extra tablets to accumulate at home, and it may be more appropriate for just a daily dosing. So be prepared to discuss those unexpected results and potentially bring the patient in for a repeat test or have that patient test more frequently if there have been red flags in the past. And for our patients who have an opioid use disorder that you are either diagnosing or that come to you with that opioid use disorder as in the past, then either offering or arranging medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapy. So again, outside of the scope of just normal kind of primary care, but knowing how to get those patients the treatment and help that they need in order to assess their opioid use disorder. So maybe that is with your nurse navigator in the office, with social work, with care management, but knowing how to refer those patients is important. So this brings us to our audience assessment question. So which of the following patients is at the highest risk for opioid overdose? So we have a 50-year-old female taking oxycodone, acetaminophen, 7.5, 325, 3 times a day after having a knee replacement. 42-year-old with COPD who takes ibuprofen, gabapentin, and hydrocodone 5, 325 every now and then. We have a 68-year-old male with a history of alcoholism who is taking hydrocodone, acetaminophen, 10, 325 3 times daily, as well as alprazolam twice daily. And a 71-year-old female taking oxycodone 5 milligrams nightly. Of course, you could argue that all these patients do have risk factors, and they do. But yes, you got it right. It looks like the majority answered the 68-year-old with the history of alcoholism. So that is somebody with a past history of a substance use disorder who is taking concurrent sedating and controlled substances, as well as that scheduled hydrocodone. Okay. All right. So moving out of the CDC opioid guidelines, we're going to now be talking about non-opioid treatments for chronic pain. So these patients, I would say it would be hard for a lot of you to go a day without seeing a patient with chronic pain of some sort. So I want you to have the tools to be able to treat these patients for the maximal benefit with non-opioid treatment. So we do want to use these to the full extent possible. That means maximizing our dose, escalating the dose of our non-opioid therapies, trying different modalities. So this means using tablets as appropriate, maybe some topical therapies, as well as using our non-pharm therapies in addition to our non-opioid therapies. We also want to use disease-specific treatments, so utilizing our therapies with FDA indications for our common chronic pain conditions, and identifying and addressing coexisting mental health conditions. So our patients who are diagnosed with depression, anxiety, PTSD, not only diagnosing those conditions appropriately and correctly, but utilizing treatments that essentially double dip. They wear two hats. They can help a patient's anxiety and depression as well as certain common pain conditions. We also want to focus on functional goals and improvement and engage patients with their therapy, explain the why behind it, and really mold the regimen to their patient preferences. So a couple of the therapies here of non-opioid therapies are listed on the left. And we can see that acetaminophen, we think of being hepatotoxic at particularly higher doses. So for most of our patients, keeping this under 4 grams per day is that safe limit. For some of our patients, it may be closer to 2 or 3 grams per day, depending on either other medications or other comorbid conditions, such as chronic liver disease. However, this is a first-line analgesic, but likely less effective than NSAIDs in some scenarios, given that it is not an anti-inflammatory medication. NSAIDs, however, are a first-line analgesic. We think of some cardiac and renal harms, as well as that GI ulcer and bleeding potential, and using COX-2 selective NSAIDs can have less GI toxicity if that's a concern for your patient. Gabapentin and Pregabalin, for our patients who are either on other concurrent sedating medications or our older patients, we do want to be aware of the sedation, dizziness, and ataxia risk. However, these are first-line agents for our neuropathic pain, and Pregabalin actually has an FDA-approved indication for fibromyalgia. When we think of our tricyclic antidepressants and our serotonin norepinephrine reuptake inhibitors, or our TCAs and SSRIs, SNRIs, our TCAs, we know they have the anticholinergic effect and cardiac toxicity potential. So our SNRIs and SSRIs really are kind of our safer and better tolerated option of this category. But we know that they do have some use in neuropathic pain as well as fibromyalgia and headaches. And finally, our topical agents, our lidocaine, capsaicin, and NSAIDs. We know that they can have some initial irritation and burning sensation with the capsaicin, but can be used in addition to the therapies above, so it can be a good approach in terms of that multimodal treatment. All right, so moving into our specific common chronic pain conditions, low back pain. I think that is arguably one of the most common ones that we see probably across different offices and specialties, and really engaging patients in this can be really critical, because we want to advise them to remain active and limit the amount of really bed rest that they have. So, like Newton's law, a body in motion stays in motion, and a body at rest stays at rest. So for patients to say, well, I can't do X, Y, Z because I'm in pain. And that's probably fair for some things, but we know that patients, if we can engage them to find activities that they enjoy and can do with their pain, it can help their overall disease state. So picking an exercise or an exercise therapy that they can do, cognitive behavioral therapy, as well as interdisciplinary rehabilitation can help. And then using our acetaminophen or NSAIDs as first line, and then our SNRIs or TCAs either second line, or if other therapies present, that it would make sense to use that first line to double dip. When we think of osteoarthritis, really some of the same things here. You'll see overlaps of exercise, weight loss, patient education can be helpful. And I'm sure I have heard many times, you have too likely that they say, well, I can't exercise and I can't lose weight because I'm in pain. So how do you expect me to do that? Well, fair, point taken, but we're not asking you to run a marathon or to be an elite CrossFitter. Walking is free and accessible to most people. And I get it on a February day in Kentucky. That's not going to be likely at the top of someone's list, but really maximizing the time that they can go outside, even if it's just a walk around the block, can be helpful. And weight loss can come from other dietary measures too. So maybe it's a referral to nutrition or dietary services could be helpful. But we can use acetaminophen, oral NSAIDs, and topical NSAIDs here, as well as some of our intra-articular injections, capsaicins, and other glucocorticoid injections as well. So our fibromyalgia, so really addressing that diagnosis and treatment, and recognizing too that it is not just a physical but a mental condition as well. But we know that aerobic exercise, CBT, biofeedback, really a kind of a total patient approach here can be helpful. But like I alluded to earlier, we do have pregabalin. It has that FDA-approved indication, as well as duloxetine and milnacipran. We also have TCAs and gabapentin here too, and we see those therapies being used in general for neuropathic pain in addition to fibromyalgia. For migraines, we do not think of opioids being anywhere near first line, but we do see it being prescribed for acute migraine use. But really, when we think of migraine treatment, we want to, first of all, prevent it. So using beta blockers, TCAs, anti-seizure medications, specific calcium channel blockers, in addition to non-pharm therapies, is really our goal of treatment to prevent that migraine. And then for the acute treatment, utilizing aspirin, acetaminophen, NSAIDs plus or minus caffeine can be helpful. Some of these therapies are over the counter, and then some of them, of course, are prescription only. But we can also kind of treat the symptoms that go along with the migraine. So using anti-nausea medication and then triptans that are migraine specific can be useful as well. When we think of non-benzodiazepine options for opioids, we have several listed on the left here, the pharmacologic therapy list here, SSRIs, SNRIs, buspirone, which of note, I see all the time being written as PRN, but really in order to be effective, this is similar to SSRIs, SNRIs, that it does need to be taken scheduled in order to be effective. We have our atypical antipsychotics, as well as mirtazapine, both off-label. You can see several off-label indications here, but really utilizing these instead of benzos is still beneficial. We see the antihistamines here, diphenhydramine being off-label, hydroxyzine I feel like we see more commonly, propranolol, anticonvulsants. So you can see it's a myriad of different drugs, different drug classes, but these can all be really utilized kind of first when we think of anxiety treatment in some patients, especially if you look at this list here too, you can see where, as we talked about, kind of double dipping or wearing two hats, picking a therapy agent where a patient has another disease state in addition to anxiety that this can be helpful for. Additionally, all of the non-pharmacologic therapies on the right-hand side, so different types of therapy, the cognitive behavioral therapy, acceptance and commitment therapy, interpersonal therapy. So a myriad of different therapy options, and I feel like it can be very easy for us to say, okay, this is your pharmacologic therapy, and do you go to therapy, yes or no? It's really easy to write that off and just chart it, yes, no, has tried in the past, but what type of therapy? What specialist was involved? Is it worth another referral? Can we get another player involved where we can really address the kind of root of the anxiety through a non-pharm way? So this leads us to, I think, our last audience assessment question. We have our patient JT, a 48-year-old male who is here for his annual physical. He has type 2 diabetes, hyperlipidemia, depression, and chronic lower back pain. So like a lot of your patients, he's on metformin, atorvastatin, buspirone daily, acetaminophen, and he has been under more stress at work and wants something stronger for his back pain. So what should we do? Should we increase his buspirone to twice daily and add hydrocodone and acetaminophen daily as needed? Should we add duloxetine 30 milligrams daily to his regimen, change acetaminophen to meloxicam plus physical therapy? Should we add pregabalin 50 daily and refer to physical therapy, or stop the acetaminophen, add ibuprofen, and add hydrocodone as needed for a short-term day supply of 7 tablets? What do you guys think? Yes, okay. So the correct answer is that add duloxetine 30 milligrams daily, change acetaminophen to meloxicam, and refer to physical therapy. And this is speaking to addressing, he's saying he's under more stress at work, so we are adding an SNRI. We're going to change between first-line agents from acetaminophen to an NSAID to hopefully help with some of the inflammation involved, as well as refer to physical therapy to get a non-pharm method on board. So good job. All right, so switching gears a little bit to naloxone, we talked about how the CDC recommends assessing risks and addressing harms, and really naloxone fits into this category of kind of addressing harms. So naloxone is a pure opioid antagonist that competes and displaces opioids at the opioid receptor site. Has a duration of action of 30 to 120 minutes. And this is important to note because some opioids have durations of actions that are longer. And so we know that we may need to give it more. And I know we're running short on time, so we do want to, I'll briefly discuss this and show here some barriers to naloxone, that it can have a stigma that is only for illicit drug overdoses. So having those discussions with patients that can be used for other uses. Sorry, I'm trying to here. So using some real world examples to portray the benefits of naloxone, like an EpiPen or a fire extinguisher, having on hand can be a good way to discuss this with patients. And these directions do come on all of the boxes on naloxone, but the important counseling point to patients is that they do not need to prime it. The dose is already ready to go, so they will just utilize this plunger method and essentially just put it up to the patient's nose and press the plunger in order to give that dose, and it can be repeated in 2 to 3 minutes if another dose is available and they're still not responding. And with that, Elizabeth?
Yeah, I think we won't go into depth with the difficult conversations, but Amanda and I really just wanted to share just some tips around how do we have these difficult conversations. So I don't have a history of addiction. Why do I need to talk about tapering? Really just outlining for the patient what those risks are, and that we don't want them to develop a difficulty with addiction either. And so, really talking through what the medical risks are and how we can help them prevent any future addiction risk. And then Amanda.
Sorry, why do I need to reduce my current dose? So really highlighting the fact that, we know that evidence has changed over time, and that if we just keep going up and up and up, that we can reach dangerous doses with really no more additional benefit, and really we're only increasing our risks of harm and misuse and overdose, as well as side effects. And then, the common thing, my insurance won't cover alternative therapies. I've tried things and they don't work for me. Acknowledging that we may have to get creative, try different therapies than we've tried in the past, and working with your available resources in the office to get other things approved.
And then, the ultimate difficult conversation, you're forcing me to get my medications from the street. So just really choosing words carefully and trying to respond in a patient-centric way and helping them to understand that our goals are the same. We both want you to have ease from your symptom distress, and let's talk through what the safest way to get there is. So just in conclusion, opioid deaths continue to be on the rise nationally and in Kentucky. We want to use our prescription drug monitoring systems frequently and to their fullest extent, use the CDC guidelines that are available, and then be prepared to have these difficult conversations. I do think there was a question in the chat that Jean answered about the DOD. Thank you, Jean, for typing in that answer. And then there was another question in the chat that Christopher had put in asking, to my knowledge, Casper doesn't capture the prescription from a long-term care facility or from methadone, Suboxone clinics. Is that true? And does Casper revamp to include this info? Jean, can you speak to that?
So inpatient dispenses are not collected either from neither from hospitals or long-term care facilities. However, depending on how some long-term care facilities handle their prescriptions, such as assisted living facilities, which sometimes use outpatient pharmacies, we do get some of those, but we don't get any inpatient. Inpatient facilities are not required to report. Only emergency departments from the hospital side, but not inpatient facilities. As far as methadone, Suboxone as prescribed by methadone and Suboxone as prescribed by X-waivered providers is reported to Casper because the federal government had basically determined that if someone was taking Suboxone for substance use disorder treatment to a pharmacy and sharing that prescription with a pharmacy, that's implied consent to participate in the pharmacy's processes. So we do get Suboxone from X-waivered providers. We do not get them from narcotic treatment programs as defined in 42 CFR, the federal statute. However, last year, the federal government changed 42 CFR and are now allowing NTPs to report to state PDMPs if required by state statute, with some significant limitations. The patients have to give consent. And so we are working very hard with the NTP providers around Kentucky to get their buy-in and to work towards their reporting to us. It will not happen before the Casper modernization. We want it to happen after that platform. And so I don't see it happening until 2023. But thank you so much for that question. We have been telling the NTP programs that it is really important to you all in the field to be able to have access to that information. So you're asking the question definitely indicates that it is important. It's been a missing link. The DOD stuff, information is a missing link as well. We were personally quite disappointed by the DOD's approach because we feel that's a big part of our public health surveillance in Kentucky as well. And if you look at Western Kentucky's prescribing rates to Eastern Kentucky's prescribing rates, they are lower. We suspect they may not be as much lower as you think because there's a fair amount of people in that area that actually get their health care and their pharmaceuticals on the bases at Fort Knox or Fort Campbell, and we don't have access to that. There's one piece I'd like to add too. We are dealing with an issue with the VA. The VA is mail ordering a lot of their prescriptions now into Kentucky as opposed to dispensing them at the facilities. And everything for the VA in Western Kentucky, almost all of it comes out of a CMOP, a centralized mail order pharmacy in Murfreesboro, Tennessee. And they're reporting it to Tennessee, which is not correct by Kentucky law or Tennessee law. If mail order pharmacies have to report to where the prescription lands. So wherever the recipient address is, that's where they report. We are working with the VA, have been for quite a little over 2 years to try to get them to report that appropriately because those prescriptions are also missing from Casper.